Roger Green, host of the Surfing the NASH Tsunami podcast. This weekend, we are offering 5 conversations from episode 18, our discussion with endocrinologist Cyrielle Caussy about intersections between hepatology and endocrinology. Plus, from the vault, conversation 49.3 from season 2, one of our first conversations about interaction with our endocrinologist friend Ken Cusi. This conversation picks up with Jörn Schattenberg, concurring with Cyrielle Caussy's statement about the importance of regular interaction and communication. I agree, and ask Jörn what he considers key to getting liver patients picked up earlier in the disease by endocrinologists or primary care, or for that matter, gastroenterology. Jörn says the specific health system pathway will matter, but that the role of nurse practitioners will be key. He also stresses the role of better information for patients. And finally, he says, we need to stress that there are things physicians can do with these patients, which will become easier to discuss once drugs have been approved. Louise Campbell agrees that this aligns with her key point about the role of allied health providers. She notes the value of VCTE in identifying disease in all kinds of patients. Jörn Schattenberg agrees, noting that at least once a week he is asked to consult on a patient whose unrelated surgery led to a decompensating cirrhotic event. All this leads to my final question. If each panelist had a magic wand and could touch one thing in their hospital and make a change, what would that be? The answers vary widely and frankly are not exactly what I expected. In an episode some 2 years ago, Jeff Lazarus made the statement, and I quote, "Hepatology cannot go it alone," end of quote. Since then, everything we've learned about the interplay of fatty liver and other metabolic diseases suggests that no specialty can go it alone, given the interplay of organ diseases and the ever-deepening challenges of poor diet and others related to social determinants of health. This episode is just one direction we should all expect to see more of going forward about working together. So just sit back, listen, enjoy, learn, and when you're done, join the dialogue in our LinkedIn discussion group.
Jörn Schattenberg.
And it's a very strong message, Roger, because it's so simple, right? And I heard Cyrielle, and I think, sometimes I got to talk to my peers and say, we got to be ready to accept these patients. When somebody reaches out and says, is this pre-cirrhotic or cirrhotic disease? That's the challenge on our side. And I think, and talking with each other, I think we can develop this.
Yeah, Jörn, thank you. That's exactly what I was thinking, which is that that's simple to execute once, in fact, everybody's bought in. And it may even be reasonably simple to get endocrinologists to buy in once hepatologists are working on it, or if you have someone like Cyrielle who actually trained at San Diego, but that's not going to happen that often. So it really does come back to, what does it take to get the hepatologist, A, to become more committed to fatty liver disease, and then B, more committed to the idea that they may be a key conduit to get patients picked up earlier in endocrinology practices. What does it take to do that, do you think?
We got to align with the endocrinologists on the NIT to be used, and I think the FIB4, as highlighted by Cyrielle, is a very good one. There could be a nurse practitioner, for example, Louise, being intermediate to do the FibroScan and actually funnel for the gastroenterologist, because they're not going to see patients with an intermediate score that then all end up just having fatty liver but no advanced fibrosis. That's the challenge on the gastro side, because they have a busy agenda and they'd really like to not see a lot of people. So we got to send over the right ones. And I think that intermediate step in it, that's going to be very system dependent, depending on, what referral pathway you're working in as a nurse practitioner in between. Reliable, what's the reimbursement for tests, and also what's the distance to the center the patient would have to drive. That's the next dimension, right? So if somebody has to travel then for a long time to see a specialist, I think the patient might not show up. What would further help? I think the information we're gathering now, we're seeing the medical information. Physicians do care, as do patients care about their health. It's not about, revenues. We want to provide the best practice. And if we know this is a high-risk patient, increased risk of death and complications because he's in a high FIB4 category, then we're ready to act on that and try to do something. And to do something is the last thing, because the gastroenterologist is going to say, I'm not a nutritionist and I'm not an endocrinologist, so what can I do and offer to the patient? And I think we're so close to having liver-directed therapies and making a recommendation for a certain therapy where there's evidence that's potentially approved for another indication, that those three challenges, A, the referral using an NIT, the reimbursement in the specific system, and the management of the patient with advanced disease is what needs to be determined, and more gastros are buying into this.
Louise Campbell.
No, I think you're right. And I think that intermediary is obviously where I talk a lot about allied health being educated, because we are the ones who are going to be the educators, and yet we're not being educated. We are the ones who interact with the patients most of the time. We are the ones that the patient calls to send the message to their physicians, and vice versa. We ran a FibroScan service which is different to FibroScan for hepatology. We received referrals from sexual health, from rheumatology. All of our rheumatology patients were screened pre to starting methotrexate. Most of those on methotrexate were now screened, but dermatology, renal. So it was an all referral system. So it was for anybody who had a potential liver health problem, not purely liver disease. And we would take out the liver disease. But if you've got that skill set, you will tell the physicians who they need to refer. You will discuss the scan with the physician, whether it's a renal physician, because that's your strength. And that is where that intermediary comes in. We do not expect, or certainly the role I have now, I do not expect all renal physicians or diabetologists or dermatologists to be experts in FibroScan. But as Cyrielle says, we've got clear parameters. We've got clear settings that we can discuss, and we know our field as intermediaries for that. And I think that's the key. I had somebody this week who had a FibroScan in a liver centre, has gone off and lost 2 stone, but actually didn't want to wait 2 years for the next scan and was high-fiving because that had made such a difference. Normalised liver stiffness, normalised liver fat. And that encouragement, because they're struggling with their job at the moment and work-life balance, can throw out their good work. So it's having that ability to have that intermediary to do that and have that skill set. And obviously it's something I argue for a lot, but it's where we have to go. You can no longer just sit in a clinic with one machine and an endocrinologist. You would be swamped by the patients you do, and you would need to take too much time. So we have to find that balance of the best screening techniques, the FIB4, the right people through either ELF, FibroScan in the recommendations. But I think going back slightly to Cyrielle's evidence on chronic kidney disease, I think what we look at for FibroScan is it is not just a test for the liver, it's a test for a poor liver that can indicate other conditions. There's some evidence on FibroScan in ITU. If it's over 17, mortality is very high. It doesn't necessarily be liver disease, it's liver engorgement. So I think we are intermediaries, and I would argue that we need more of us to be able to do that in that skill set.
So how practical is that in the setting, Jörn and Cyrielle, in the settings that you're working today? How practical is it that you get more of that support in your institutions? And what do we have to do to get there?
Cyrielle Caussy.
Excellent question. Well, I think it's key, nurses and platform. Yeah, definitely. It can provide more time to get access to the assessment, saving medical time. It's absolutely necessary to bring more, nurses in the French system. They are not very well implemented and use as they should be, I would say. But definitely we need more. And actually the FibroScan as well in my department is performed by the nurses. So this is really important.
I would implement it at the hospital level. I mean, this is a whole different thing, even in the inpatients, and argue. I get about 1 consultation a week for a patient that decompensates after major surgery. And somebody didn't know they had cirrhosis. And this means they have an extra 10 days on ICU with respiratory time, with infection, potentially lethal complications, just because we didn't see cirrhosis before we did surgery. And these type of things can even be at the, we're not talking identification of NAFLD, but the cirrhosis identification for a healthcare system here could be crucial. Now, in our specific question, I think it would be in the interest of the hospitals to provide this additional service, and it has to be very carefully set up how it's reimbursed in the specific systems. The hospitals don't always have the same capabilities as outpatient clinics, and therefore this might be even prior getting to the hospital, but it depends on the system that you operate.
So we're getting to the top of the hour, so I think it's probably time to look to a final question. First of all, Cyrielle, Jörn, Louise, thanks. Fascinating discussion. I think really important stuff. And we're covering some territory here we've never covered on this podcast. 187 episodes in, that's an interesting challenge to meet. If we can cover new territory every week, I'll feel really good about that. So this is great. Closing question. Each of you has a magic wand. You can touch one thing in this structure, and in 12 months from now, it'll be exactly what you want it to be. What's the one place you would touch?
Can I go first?
Sure.
Yeah, you can.
I would transfer Cyrielle next to my department, and I would want to be working with her in a joint research composition here and have a joint gastro endocrinologist service.
Yeah, that's probably, as you said, we have set as a very special skill, but it took a long time and a lot of training to get to that knowledge. So probably magic wand to spread the word and spread the knowledge everywhere so that we are all in the same level. That would be fantastic.
Mm-hmm. That's the realistic approach. Yeah, I think think it's the working, extending the working together. I think that's what it is. And it just takes time to approach the patient. And I have the same experience as Cyrielle said. If you start talking to your endocrinologist and say, well, this is interesting, what can you offer? And they know their patients are multi-system diseased, and it's just implementing it in very busy clinic days with all of them doing excellent jobs every day in managing those patients, and just adding a little bit is just a challenge.
I suppose my magic wand is the practical side, that I would look at introducing the screening and maybe the liver at pre-diabetic level so that they're used to it very early, and then we do it. But we're also looking for the more severe disease in the established diabetes clinics so that we're going to reduce it coming forward and find the severest cases. So if I had that magic wand, there would be the stratification of FIB4, the ELF, FibroScan, and some evidence at EASL last year was do FibroScan in type 2 diabetes before FIB4 was some of the papers that I'd seen as well. So either way, but let's stop the pre-diabetics getting to cirrhosis and use liver engagement very early so it becomes a yearly thing for them and they don't know any different. And I think that's the key. Those who are long established will know different when we start to introduce it.
Louise, I think our wands are in similar neighborhoods. If in fact the wand has a place where it lives, it would be a similar place. If in fact we started at the same pace and with the same frequency that we test pre-diabetic and diabetic patients for their other complications, neuropathies, nephropathies, eye issues, we incorporated liver on that list. Starting at pre-diabetes, I think we would start to see enough data and enough experience quickly enough that everybody would get a lot more serious about this. And that's probably, I think, the fastest practical way to get there. And I'm with you. I love Jörn's solution. And in fact, if we could clone Jörn and Cyrielle into about 1,000 pieces each, drop both of you down in all of the world's major academic and large non-academic institutions, we can solve this problem in a week and a half. You realize that, right?
Yeah, that's ambitious.
So how are we doing with cloning these days?
Treatment at the end, but this is the other magic wound. But hopefully it's coming. But effective treatment would be the cherry on the cake, right?
So Cyrielle, again, thanks for joining us today.
And now back to Roger.
We hope you've enjoyed this recording. If you have any questions or comments about the content of this conversation or the entire episode, please put them in the review section of the page from which you downloaded this conversation, or send an email to questions@surfingnash.com. Next week, while we are spoiled for choice, we have not decided exactly what topic to cover next week, but I promise you it'll be a good one. So until then, stay safe, surf on. We'll see you on the podcast. Bye-bye now.